Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of obstructive sleep apnea and adenotonsillar hypertrophy, designed for general pediatricians. Obstructive sleep apnea is far more common in children than many people realize, and adenotonsillar hypertrophy is by far the leading cause. Untreated, it affects growth, behavior, learning, and cardiovascular health. Across the next cases, we will cover clinical presentation, physical examination, including the Brodsky grading scale, pathophysiology and adenoid facies, diagnostic workup, severity classification, treatment, special populations such as Down syndrome, complications, postoperative care, and key differential diagnoses. Let us begin. Case 1. A 5-year-old boy is brought to the clinic by his mother due to restless sleep. She reports he snores loudly every night, often gasps for air, and appears to stop breathing for several seconds. During the day, he is irritable and has difficulty concentrating in school. Which nocturnal symptom is most pathognomonic for obstructive sleep apnea in this child? Option A, habitual snoring without pauses. Option B, paradoxical ribcage movement. Option C, sleep talking and night terrors. Option D, diaphoresis in the first half of night. The correct answer is option B, paradoxical ribcage movement. Paradoxical movement, where the ribcage moves inward instead of outward during inspiration, indicates very high upper airway resistance and a marked increase in the work of breathing. It is one of the most specific physical signs of true airway obstruction in a sleeping child. Snoring is extremely common in children and lacks specificity on its own. Observed gasping and witnessed apneic pauses are highly suggestive of obstructive sleep apnea, but the paradoxical chest wall movement directly reflects the mechanical struggle against a collapsed pharynx. Daytime irritability and attention difficulties are common secondary manifestations of fragmented, non-restorative sleep. Case 2. During the physical examination of a 6-year-old girl with suspected obstructive sleep apnea, you observe her tonsils. They appear to meet in the midline, almost touching each other, significantly narrowing the oropharyngeal space. According to the Brodsky grading scale, how should these tonsils be classified? Option A, grade 1+. Option B, grade 2+. Option C, grade 3+. Option D, grade 4+. The correct answer is option D, grade 4+. The Brodsky grading scale is a quick visual tool used to estimate how much of the oropharyngeal airway is occupied by the tonsils. Grade 1+ means the tonsils occupy less than 25% of the airway. Grade 2+ is between 25 and 50%. Grade 3+ is between 50 and 75%. Grade 4+ means the tonsils occupy more than 75% of the airway and often touch in the midline. These are commonly described as kissing tonsils. However, remember that tonsil size at rest does not always predict the severity of airway obstruction during sleep, so the clinical picture and sleep study findings still drive management. Case 3. A 4-year-old child with chronic nasal obstruction and mouth breathing presents with a long, narrow face, a high arched palate, and dental crowding. The mother mentions he has always looked this way. This constellation of craniofacial findings, often associated with chronic adenoid hypertrophy, is known as option A, adenoid facies, option B, Crouzon syndrome, option C, Pierre-Robin sequence, option D, Treacher-Collins appearance. The correct answer is option A, adenoid facies, sometimes called long face syndrome. This appearance develops when chronic adenoid hypertrophy forces a child into prolonged mouth breathing during critical years of craniofacial growth. Key features include an elongated face, an open mouth posture with a dull expression, pinched nostrils, a shortened upper lip, a high-arched hard palate, and dental malocclusion with crowding. Crouzon syndrome, Pierre-Robin sequence, and Treacher-Collins each have distinct genetic and structural features that are not produced by adenoid hypertrophy. The take-home message is that long-standing upper airway obstruction is not just a sleep problem. It can permanently shape the face, the bite, and the airway. Early recognition and intervention can prevent these changes. Case 4. You are evaluating a 7-year-old child with heavy snoring and daytime sleepiness. The parents ask if a home sleep study is sufficient or if they need to go to the hospital for a full overnight test. What is considered the gold standard for diagnosing obstructive sleep apnea in the pediatric population? Option A, nocturnal pulse oximetry. Option B, in-lab polysomnography. Option C, lateral neck X-ray for adenoid size. Option B, home sleep apnea testing. The correct answer is option B, in-lab polysomnography. In-lab polysomnography is the gold standard for diagnosing pediatric obstructive sleep apnea and for quantifying its severity. It records multiple parameters at once: brain activity through electroencephalography, airflow, respiratory effort, oxygen saturation, and end-tidal or transcutaneous carbon dioxide levels through capnography. Unlike in adults, home sleep apnea tests are less reliable in young children because of high false negative rates and difficulty obtaining accurate respiratory effort signals. Nocturnal pulse oximetry alone may suggest disease when severely abnormal, but a normal study does not exclude obstructive sleep apnea. Lateral neck X-ray can assess adenoid size, but does not diagnose sleep apnea. Case 5. A 5-year-old's polysomnography report shows an apnea-hypopnea index of 7 events per hour. The child has no underlying medical conditions. How would you classify the severity of this child's obstructive sleep apnea? Option A, primary snoring or normal. Option B, mild obstructive sleep apnea. Option C, moderate obstructive sleep apnea. Option D, severe obstructive sleep apnea. The correct answer is option C, moderate obstructive sleep apnea. In children, the apnea-hypopnea index thresholds are much stricter than in adults. An index of less than 1 event per hour is considered normal or primary snoring. An index of 1 to less than 5 events per hour is mild. An index of 5 to less than 10 events per hour is moderate. An index of 10 or more events per hour is severe. An index of 7 therefore falls clearly into the moderate category. These thresholds are deliberately strict because even relatively low-frequency obstructive events can affect neurodevelopment, behavior, growth, and cardiovascular health in children. Severity classification directly guides management decisions, and most moderate to severe cases will require surgical intervention. Case 6. A healthy 4-year-old boy is diagnosed with moderate obstructive sleep apnea with an apnea-hypoapnea index of 8 due to grade 3 plus tonsils and significant adenoid hypertrophy. He has no other comorbidities. What is the recommended first-line treatment for this child according to American Academy of Pediatrics guidelines? Option A, continuous positive airway pressure. Option B, intranasal corticosteroids for 6 months. Option C, adenotonsillectomy. Option D, weight loss and positional therapy. The correct answer is option C, adenotonsillectomy. Adenotonsillectomy is the recommended first-line treatment for most otherwise healthy children with obstructive sleep apnea and adenotonsillar hypertrophy, according to American Academy of Pediatrics guidelines. Success rates are high, with roughly 75 to 85% of healthy children showing resolution of disease after surgery. Success is lower in obese children and in those with craniofacial anomalies or syndromes who often need additional therapy. Medical therapy with intranasal corticosteroids, with or without montelukast, may be considered for very mild disease or as an adjunct, but is not first line in moderate or severe cases. Continuous positive airway pressure is reserved for children who are not surgical candidates, have residual disease after surgery, or have severe disease pending surgery. Case 7. A 3-year-old girl with Down syndrome presents with severe obstructive sleep apnea. Her parents are concerned about the risks of surgery and ask if she is at higher risk for complications. Which factor contributes most significantly to the high prevalence of obstructive sleep apnea in children with Down syndrome? Option A, isolated adenoid hypertrophy. Option B, generalized hypotonia and macroglossia. Option C, recurrent viral upper respiratory infections. Option D, excessive lymphoid tissue in the larynx. The correct answer is option B, generalized hypotonia, and macroglossia. Obstructive sleep apnea affects up to 50 to 60% of children with Down syndrome, which is why current guidelines recommend a baseline polysomnogram by around 4 years of age in this group, even in the absence of symptoms. The high prevalence is driven by a combination of anatomical and functional factors: midface hypoplasia, a relatively large tongue causing macroglossia, a small upper airway, and generalized hypotonia that produces a floppy, collapsible airway during sleep. Adenotonsillar hypertrophy still contributes, but it is rarely the only factor. As a result, adenotonsillectomy alone is less successful in this population, and many children also need continuous positive airway pressure or other adjunctive therapies. Case 8. An 8-year-old with untreated severe obstructive sleep apnea with an apnea-hypopnea index of 25 is being evaluated. You are concerned about the long-term cardiovascular impact of chronic intermittent hypoxia and hypercapnia. What is a well-documented cardiovascular complication of chronic, untreated severe obstructive sleep apnea in children? Option A, coarctation of the aorta. Option B, pulmonary hypertension and cor pulmonale. Option C, mitral valve prolapse. Option D, tetralogy of Fallot. The correct answer is option B, pulmonary hypertension and cor pulmonale. Chronic intermittent hypoxia causes pulmonary vasoconstriction, which over time leads to pulmonary hypertension and eventually right ventricular hypertrophy, known as cor pulmonale. Other well-recognized consequences of chronic, untreated obstructive sleep apnea in children include systemic hypertension, systemic inflammation, insulin resistance, and metabolic dysregulation, all driven by chronic sympathetic activation and oxidative stress.